Good day, I'm Dr. Anas Ahmad Sabir. I'll be presenting insulinoma as part of Module 6 activity for Diploma in Endocrinology. I'll be presenting under the following outline: introduction, clinical features, investigations, treatment, differential diagnosis, and the summary. Insulinoma is an insulin-secreting tumor of the endocrine pancreas that causes hypoglycemia. Although it is the most common functioning tumor of the endocrine pancreas, but it's usually a rare disorder because it occurs in about 1 to 4 cases per million of the general population. It is a usually benign disorder, and more than 80% of the tumors are solitary. It may occur in association with other syndromes, especially the multiple endocrine neoplasia 1 syndrome. The clinical features are mainly those of hypoglycemia secondary to endogenous hyperinsulinism. Usually the symptoms are episodic due to the intermittent secretion of insulin by the insulinoma. The Whipple triad is usually demonstrated in the insulinomas. The Whipple triad comprises of clinical evidence of hypoglycemia, biochemical evidence of hypoglycemia, and resolution of symptoms with administration of glucose. The clinical features are predominantly those of subacute neuroglycopenia, leading to delay in making diagnosis. These neuroglycopenic features imitate features of psychiatric illness, and therefore a misdiagnosis may be made. The neuroglycopenic features include irritability, confusion, personality changes, aggression, visual blurring, diplopia, convulsions, and coma. Adrenergic symptoms can occur. These include sweating, pallor, tremor, hunger, palpitations, and tachycardia. It is also important to know that the clinical features are more pronounced in the fasting state or after an exercise, and weight gain and obesity can occur in 30% of patients. The investigations are divided into two. We have the investigation to establish diagnosis. We also have investigations to localize the tumor. The most important investigation, which is the gold standard to diagnose insulinoma, is the 72-hour fast, which is done as follows: baseline investigations, the insulin, C-peptide, proinsulin, fasting blood sugar, and beta hydroxybutyrate are taken. Then the blood sugar is checked every 2 hours until the blood sugar is less than 60 milligram per deciliter, and then it should be checked hourly. We stop the test when the blood sugar is less than 45 milligrams per DL. A diagnosis of insulinoma is made after the 72 hours fast when the following parameters occur: when there is a decrease in glucose level, when there is inappropriately increased insulin levels greater than 6 microunit per mil, when there is increased C-peptide level, when there is increased proinsulin levels, and when the beta hydroxybutyrate is decreased to less than 2.7 millimoles per liter. All this should occur in the absence of sulfonylurea secreting in the plasma or the urine. The investigations for tumor localization include the MRI or CT, especially the spiral CT scan. This detects tumor in about 60% of cases. Other very important ones include arterial stimulation with calcium or secretin, followed by venous sampling. It localizes tumor in about 90% of cases. Endoscopic ultrasound scan identifies even small tumors as small as 5 millimeters in about 80% of cases. Intraoperative ultrasound scan improves the sensitivity of the ultrasound to about 90% sensitivity. Other important tests that can be done include somatostatin receptor scintigraphy. The treatment generally is the surgical removal of the tumor. That is the mainstay of the treatment, which has 97% success rate in the hands of an experienced surgeon. Successful removal of the tumor leads to normal life expectancy. This tells us that the tumor has a good prognosis if the diagnosis is made and the treatment is done early before metastasis. Pre-operative treatment with diazoxide may improve the surgical outcome. Medical management of the tumor using diazoxide or octreotide can also be used, but these treatments are employed in patients that have inoperable tumors or patients that are poor candidates for surgery. Other medical treatment that can be used, streptozotocin is beneficial in patients with islet cell tumor, and radiolabeled somatostatin analog therapy for malignant insulinoma can be used. The differential diagnosis include non-insulinoma pancreatogenous hypoglycemia. This occurs when there are islet cells hypertrophy. Other differentials include insulin autoimmune syndrome, non-fasting hypoglycemia, non-pancreatic tumor hypoglycemia as occurs in hepatocellular carcinoma, others hypopituitarism, adrenal insufficiency, or factitious hypoglycemia that occurs in people that take exogenous insulin or sulfonylureas, especially when they are seeking for attention. The summary is that of insulinoma usually present with fasting hypoglycemia, although a certain percentage may present with postprandial hypoglycemia. The insulinoma is diagnosed by finding elevated serum insulin, C-peptide, proinsulin, and decreased hydroxybutyrate, all in the absence of sulfonylurea screening during a supervised fast test. The treatment of insulinoma is mainly surgical excision. However, medical treatment with medications such as diazoxide and somatostatin analog may be useful, especially in those that have inoperable tumor or cannot withstand surgery. I thank you very much for listening to the presentation, and I hope the presentation will be useful to you. Thank you very much.